So welcome back to APCCC Diagnostics. It was an excellent start yesterday already, room full, and I think most of the people seem to be taken up this Swiss way of living and being here also in time. Room fills up, so very good. We have session 3, which is addressing biochemical recurrence, and I would like first to thank Silke, Aurelius, Stefano, and Ken for getting me involved here in this very nice meeting. I'm really honored, and it's a pleasure being here. I was asked to talk about biochemical recurrence and to set the stage. When do we need to act? These are my disclosures. Some of them might be relevant for this presentation. Probably all in the room here are well familiar with the definitions of biochemical recurrence after a local treatment of localized prostate cancer. After radical prostatectomy, it's defined by the EAU, ENM, ESTRO guidelines to be a rising PSA, confirmed to be rising. After radiotherapy, it's the PSA nadir plus 2 nanograms per ml. And when the ESTRO consensus published their first definition of biochemical recurrence after radiotherapy, the 3 consecutive rises, the older in the audience might remember this one, in 1997, they very correctly stated that biochemical failure is not justification per se to initiate additional treatment. It is not equivalent to clinical failure. And I think we need to keep that in mind the entire time we talk about biochemical recurrence. That's why I would like to stress this here. We need to keep that in mind because not all PSA changes or rises we might see after local treatment will lead to further progression. You can use different PSA cutoffs. That was used for probably a decade, a PSA cutoff of 0.2 to define biochemical recurrence. You take this one, for example, only 50% of the patients will have further PSA increases, further progression to metastases. You take a PSA cutoff of 0.3, 60% of the patients will further progress. And you take a cutoff of 0.4, actually 70% of the patient will further progress. That's why the 0.4 cutoff actually is the one that is best correlated to further progression of the disease, but it closes the window that we might have with very early salvage treatment, and I will have some slides on this at the end of my presentation. And we have a similar situation when it comes to radiotherapy. We can have the nadir, the lowest PSA we ever had after the treatment, and then add a certain amount of PSA to it, nadir plus 1, plus 2, plus 3. You will see that defining or changing that additional PSA you might have over the nadir will change the sensitivity and the specificity. You take PSA nadir plus 1, the blue columns, you have a high sensitivity but a low specificity. A lot of patients will be called having a failure. Actually, they don't have a lot of false positives. You take a higher cutoff, PSA nadir plus 3, the green columns, the sensitivity is going down, but the specificity is going up. You have few false positives. And the best trade-off seemed to be the PSA nadir plus 2. That is what the consensus guided by Mac Roach actually concluded in 2006. And that is probably the most important slide we could have when it comes to biochemical recurrence. It shows you the natural history of biochemical recurrence, of untreated, how the authors claim, biochemical recurrence from the Johns Hopkins series, Pound data published a few years ago. And actually it took usually 2 to 3 years to have the biochemical recurrence after radical prostatectomy. Once you have it, it takes 8 years in the median to develop metastases. And then once you have metastases, it takes additional 5 years to die of the disease if you're prone to die of the disease. So it's a slowly progressing disease as prostate cancer in general, and biochemical recurrence is associated to, in general, a good prognosis. So many patients might just live with their biochemical recurrence, might not die of prostate cancer, but some do so. And we would probably need to identify those who are at risk of progression. And we can use here the usual suspects, clinical stage or pathological stage, lymph node status, and the Gleason or the ISUP score. Many of the clinical stages or the local stages actually lose their predictive value once you have a biochemical recurrence. That is true for radical prostatectomy, that is true for radiotherapy, and only the Gleason grade or the ISUP grade actually is informative to tell you if a patient will further progress once he has biochemical recurrence. What probably is more helpful is the time point of biochemical recurrence. The earlier you have the PSA rise after local treatment, the higher the likelihood that the patient will progress later on. And the cutoff is probably somewhere between 1 or 2 years, no matter if you go for radical prostatectomy or radiotherapy. And then we have PSA kinetics. The beauty here is you treat the prostate, you don't have any benign source of PSA anymore, and this change in PSA is directly linked to tumor biology. And you can take the PSA velocity, the increase of PSA per year, or you can take the PSA doubling time. And the shorter the PSA doubling time, the faster the PSA rises. In the very beginning, when we were exploring this, we tried to identify a cutoff that is linked to a progression, but probably the smarter way of dealing with this is taking it as a continuous variable. The shorter the PSA doubling time, the higher the likelihood the patient will progress. You see here the hazard rates, and you see a steep increase when it comes to a doubling time around 6 months. That is probably where really the prognosis is substantially changing. And we can also use the PSA doubling time to identify those who are at risk of dying of prostate cancer and who might die of other causes. Once more, Johns Hopkins data, the same data set Pound was already working on. Stephen Friedland was working on this one as well. And you see here superimposed the all-cause mortality, including prostate cancer mortality, and the prostate cancer-specific mortality in yellow. If you have a PSA doubling time of 3 to 9 months or 9 to 15 months, you see that the lines are overlaying, telling you that the prostate cancer mortality is responsible for basically the all-cause mortality. Only if you have a higher PSA doubling time, above 15 months, you see that on the right-hand side that the curves separate, and here you see that actually in addition to the prostate cancer mortality that is low, the all-cause mortality, the other cause mortality actually acts to the mortality. Here the patients are dying of other causes than prostate cancer. That is not the case for lower PSA doubling time. So we're able to identify those who might just live with their biochemical recurrence but not die of their biochemical recurrence. And the EU ENM ESTRO guidelines, they defined risk groups for progression or non-progression in biochemical recurrence. If you have a PSA doubling time above 12 months, ISO grade group of 4 or lower after a radical prostatectomy, or an interval between radiotherapy and BCR of more than 18 months, and a biopsy score of 4 and lower, then you have low risk. And if you have the other way around, you're high risk. If you have low risk, you might be managed with monitoring. If you're high risk, you should probably receive treatment because you're at risk of progression. And this seems to work nicely in clinical practice. You can separate those who really will progress and not progress. I was telling you already that the PSA cutoff that might define biochemical recurrence and that might trigger a further treatment is of importance. You see here the outcome of patients treated with salvage radiotherapy after radical prostatectomy stratified according to the PSA at the time point of salvage radiotherapy. The lower the PSA at the time point of salvage radiotherapy, the higher the efficacy. A 0.2 cutoff would result in 60% cure rate on the long term, a 0.5 cutoff, 50% of cure rate on the long term. And if you have higher PSA ranges, then actually you will not be able to be as efficient as you are with a low PSA range. So we're a little bit in a conflict of interest. We would like to have a higher cutoff to make sure we do not have false positives. On the other hand, the earlier we treat, the more effective we are. And if you put that in a prospective scenario, this is Radical's RAVES G217 that compared salvage radiotherapy with adjuvant radiotherapy. The red lines here on the right-hand side are salvage radiotherapy. The blue line on the left-hand side is salvage radiotherapy. You do it very early, 0.1 or 0.2 in a systematic fashion. 80% of your patients will be cured in the long term. A very effective treatment in these patients, probably linked to a certain extent also to overtreatment, obviously. But this was compared to adjuvant radiotherapy, where basically everybody was treated. So salvage radiotherapy in this situation is already a de-escalation of treatment. We are hosted, we have the honor, by nuclear medicine physicians, by Ken and Stefanos. I would need to address quickly at the end also PET imaging to see how that can help us to judge the risk of progression and to classify our patients who we need to treat or not. This is a series from Louise Emmett that looked prospectively at the use of PSMA in a salvage setting, and she could nicely show if you have a negative PSMA PET or only a PET positive at the prostate bed, you do way better than if you have a PSMA positive somewhere else. And here they left the treatment to the discretion of the treating physician. I will have another slide where that was different. But what is interesting here, so you can stratify PSMA negative or only the bed positive versus outside of the prostatic bed nicely. And if you add then here the PSA cutoffs that so nicely separated patients in the series I just showed you, you see that the PSMA obviously seems to overrule these PSA cutoffs. It is probably a more important predictor of outcome of the patient than what we can do with PSA. So PSMA obviously is a very important predictor for the outcome of salvage radiotherapy. And that is another study, fluciclovin. I like it very much, few patients included, but here they defined how to treat the patients patients that do have a positive lesion based on fluciclovin before a salvage radiotherapy. And you see here clearly, if it's all negative, the patient do very well. If you have a prostate bed that is positive, you do reasonably well. And if the lymph nodes, despite the fact that they were systematically treated that are positive in fluciclovin, then you do not as good. So PSMA PET or fluciclovin is obviously very helpful to identify those where we might need to intensify and where local treatment alone might be enough, or where the patient might actually be under surveillance. So in conclusion, when do we need to act? BCR is a heterogeneous clinical scenario, we know that. Before treatment, you should estimate life expectancy and cancer potential for progression to make sure that we help our patients with the outcome of their disease. After monitoring, a patient do have a low risk of progression. Offer early salvage treatment if you have a high risk of progression. And better treatment selection will obviously improve outcome, and I think PET PSMA or PET imaging in general will help us with this task. And with this, I thank you very much for your attention. And I would like to